Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Ahmed Darwish, Associate Professor of Pediatric Hematology, Oncology, and Bone Marrow Transplantation. I'm going to speak about the classification of anemias and the etiology and how can we diagnose anemias. First of all, we have to know that in order to diagnose or to define anemia, we have to say that it is a decrease or a reduction in the hemoglobin level, hematocrit value, and or the number of RBCs. However, the normal hemoglobin differs according to the age and sex. Of course, the androgen in males is going to stimulate the bone marrow. So what is happening is, starting from the adolescent age group, hemoglobin levels in males is more than in females because of androgen. And according to the age, we have to know that the baby who is being born, or even in the fetal life, the baby is receiving venous blood from his mother. And that's why there is some sort of hypoxia, intrauterine hypoxia. And the fetus, in order to be adapted to this hypoxic media, what's happening is that erythropoietin level is increased, which means that there is more and more bone marrow stimulation. So the RBCs and the hemoglobin levels are higher than expected to adapt to this situation. Not only that, but the hemoglobin F is also high, about 70%, to have got a high affinity for oxygen. And that's why we can see that the baby, when being born, his hemoglobin level is very high. And this is clear from this table, which shows that hemoglobin level at the age of 1 in the first day of life, a minimum level of hemoglobin is 14.5 gram per deciliter and a maximum limit of 22.5. And this value, the least value for normal hemoglobin, is decreased gradually, rapidly. We can say it's rapidly. So by the first week of life, the cutoff limit for anemia, which was 14.5 at birth, becomes 13.5 after 1 week, then becoming 12.5 after 2 weeks, and 10 after 1 month, and 9 after the age of 2 months. And we call this the nadir, or we call it physiologic anemia of infancy. Then rises back to 9.5, 10.5, and at the age of 2 years to 6 years, it's 11.5, then up to 13 and 12, then up to the adolescent adult levels, about 13.5 cutoff limit of anemia in males and 12 cutoff limit of anemia in females. So what's happening is that the hemoglobin was very high, then decreases rapidly until the age of 2 months, then rises back, but it will never go back to the very high values at the age of the first day of life. The same also occurs in the MCV, the mean corpuscular volume, where the mean corpuscular volume differs according to the age, being the largest, the largest size at the first day of life. It's about 95 up to 121. Then decreases rapidly until the age of 6 months to be 70 to 86. Then rises back to reach from 83 to 101. So what's happening for the size of RBCs also, that they are very large, then decreases in size, then enlarge again. For white blood cell count, as it's clear that the white blood cell count is very high in the first day of life, ranging between 9,000 up to 30,000, and then decreases the cutoff limit for, or the cutoff value for leukocytosis, becoming 21,000. Then at the age of 1 month, it's 19.5. And then at the age of 6 months to 1 year, it's 17.5. At the age of 2 years, it's 17,000, and decreases until it reaches its minimum value in the adolescent age, from 16 to 21 years, to be from 4.5 thousand to 11,000. But what's significant is that the platelet count is the same from the first day of life until adolescence. Okay, what are the general manifestations of anemia? Of course, anemia have got many symptoms and signs. One of the most important is presence of pallor. Of course, the patient could be presented with anorexia and fatigue, but the heart is trying to compensate, and there may be tachycardia and palpitation, and even the heart may not be able to adapt, and they may fail. Heart failure usually occurs in acute anemias rather than in chronic. It may occur in both, but in acute it's more common. And of course, because of the high velocity of blood and the tachycardia, we can hear a murmur. We call this murmur functional murmur, hemic murmur, which will disappear after the disappearance of anemia, of course. Where we can look for pallor, of course, pallor is a symptom and sign. We can look for pallor in the inner side of the lip, the palpebral conjunctiva, even in the palm creases as well, to compare the hand of the patient with the examiner's hand, and the nail bed, of course. Okay, as regard history, of course, whenever we want to take a history from a patient, we have to rule out the etiology, the different causes of anemia in this child. So we have to ask about diet, because we all know that iron deficiency anemia is the most common cause of anemia in all age groups and worldwide. So we have to ask about the nutritional history, which means that what type of food the baby is receiving, and is he receiving only junk food, or is he receiving iron, or is there any bad habits during eating food which is rich in iron, like eating something which could be a chelating agent to this iron. We have to ask also about history of diet which is related to the appearance of anemia. For example, those who are having G6PD deficiency may show hemolysis and anemia after ingestion of fava beans. We have to ask about history of drug intake. For example, asking about drugs which can cause bone marrow suppression, like chloramphenicol, sulfonamides. We have to ask also about intake of some medications like antimalarial drugs or sulfa-containing drugs, because these can lead to attacks of hemolysis in patients with G6PD deficiency, or even anticonvulsants sometimes. Don't forget also to ask about history of hemorrhage, either acute or chronic, even menorrhagia, accidents, invasive procedures. We have to ask also about the presence of jaundice and dark colored urine and abdominal enlargement. Also, we have to ask about history of purpura, ecchymosis, bleeding, fever, weight loss, because it could be an aplastic anemia, it could be a leukemia. You have to ask about body swellings in the neck. You have to ask about body swellings in the axilla and the groin. Don't forget also to ask about positive family history of similar condition, and history of consanguinity, history of splenectomy, history of cholecystectomy even, because this is common in patients with hemolytic anemia, especially in spherocytosis. Also, in order to treat anemia, we have to classify it either one of three according to the size of RBCs. Either it's microcytic or normocytic or macrocytic. To know the class of anemia, we have to know the blood indices, which are the mean corpuscular volume, MCV, mean corpuscular hemoglobin, MCH, and mean corpuscular hemoglobin concentration, MCHC. And what's mean corpuscular volume? It means that the volume of whole RBCs, which is a hematocrit, divided by the number of RBCs in millions, multiplied by 10, which could be between 87 to 72, about 90 femtoliter. And an MCH, which is the hemoglobin divided by the RBCs multiplied by 10, so it could be 30 picogram. And the MCHC means it's the hemoglobin over the hematocrit multiplied by 100, so it's about 33%, which gives you an idea about how much size of the RBCs the hemoglobin is occupying. And in order to know exactly what figures are important in pediatrics, especially MCV, we can consider an RBCs to be small in size if its MCV is less than 75. Of course, if we want to know accurate figures, we have to go for the table. And the MCV of more than 100, we call it macrocytosis. And we call the cell hypochromic if the MCH is less than 27. And the figure below shows the blue dots. It is MCV, and the red part in the left is MCH. If we divide MCH by the MCV, we get the MCHC, which is a concentration. And if you look to the figure above, it's a biconcave shaped RBCs. It's an electron microscope figure, but in order to know whether these cells are biconcave in shape or not, of course, we don't have to go for electron microscope, but we have to do what we call blood film. And now, what the difference between a CBC and blood film? And is it important to do both in the beginning, initially, or it's enough to do a CBC? We don't have to do blood film. Actually, blood film is very important. A CBC is just a count, but the blood film can tell you not only the count, but can tell you also the size, can tell you the shape, can tell you that if there are any abnormalities or infiltration of the blood itself. Even sometimes it can correct some troubleshooting or some mistakes done by a CBC machine, because as we all know that the RBC size is, is in between white blood cells and platelets. White blood cells are the largest, then RBCs, and the smallest are the platelets. So sometimes, for example, in patients with acute hemolysis, the bone marrow is trying, if we have hemolysis, so we have anemia, like in G6PD, for example. Those who have got hemolytic attacks in G6PD can have a very low hemoglobin level and RBCs count, so a hemoglobin could be of 3 or 4. At the same time, the bone marrow is trying to compensate, so the bone marrow will release many immature forms of RBCs like normoblasts. These normoblasts are very large in size, larger than the RBCs. So it could be mistaken by a CBC machine to tell you that these are white blood cells. So sometimes when you look for a CBC for a patient with G6PD, the white blood cell count is a little bit higher than expected. And if you have white blood cells which are increased in amount and hemoglobin is low, so some parents becomes very anxious, or some even physicians becomes very anxious because it could denote leukemia. But of course, to know that these large cells are not white blood cells, are not blast cells, but they are only normoblast, so you have to do a blood film. So blood film is important in this situation, for example. Another situation is that whenever you have a patient with severe iron deficiency anemia, because in iron deficiency anemia, the RBC size is very small in size. So if they get small in size, it could just be looking like the size of platelets. So a CBC machine can count them as platelets. So you would have what we call thrombocytosis because of these faulty red RBCs, very small RBCs. And if you can just look here, it's clear that the blood cells are decreasing in size, and the nucleus is going to disappear. So as you can see that whenever we have sometimes hemolysis, these normoblasts will go to the peripheral blood and could be read by a machine, a CBC machine, as white blood cell, which is just a mistake. This blood film shows the normal size of RBCs, but the count is low, so it's a normocytic normochromic anemia. And it's clear here from this cell, for example, that it have got what we call central pallor sign. So if you have got a central pallor sign, this means that it is a biconcave in shape. However, if you look here, the central pallor is wider and the size is smaller, so it's microcytic hypochromic, like in iron deficiency anemia. But these cells are a little bit larger than expected, so this is called macrocytic anemia, which is common in megaloblastic anemia. We call them vitamin B12 and folic acid deficiency. Okay, so if you go for the causes of anemia, we have either microcytic anemia, normocytic anemia, macrocytic anemia. Microcytic anemia being the most common, but normocytic anemia being the most dangerous. The microcytic include the iron deficiency, the thalassemia, which is the only hemolytic anemia which is microcytic, and sometimes it's sideroblastic anemia, chronic infection, renal failure, chronic lead poisoning, even copper deficiency, and so on. For normocytic normochromic anemia, it could be all hemolytic anemia other than thalassemia, or except thalassemia. We have hemorrhagic anemia, especially acute hemorrhage, because chronic hemorrhage will lead to microcytic anemia. Of course, leukemia, aplastic anemia, all these can lead to normocytic anemia. But what about macrocytic anemia? It could be in the newborn, or megaloblastic anemia, or some nucleic acid abnormalities like orotic aciduria. Let's speak about iron deficiency anemia, because this is the most common type of anemia we all know. The most common age to develop iron deficiency is at the age between 6 months and 2 years, because this is the age of weaning, and the mother have to take care of the baby's diet. And breastfeeding, as you know, is not rich in iron, and the baby should be supplemented with food which is rich in iron starting from the age of 6 months, even before sometimes. But there are other big ages for iron deficiency. Iron deficiency anemia can occur in all age groups, but as we just said, it's very common in weaning age, in puberty females, even in the school age, because whenever a mother is making her child go to school, so she will not feed him anymore, but she will depend on others who will feed him in the school, for example. What about the causes of iron deficiency? Either inadequate intake, like decreased intake, cow milk, decreased stores like twins, like malnutrition of the mother, bleeding of the mother, fetal blood loss, and so on. It could also be related to inadequate absorption, like the presence of steatorrhea, the presence of GI operation, the presence of steatorrhea, congenital anomalies of the GI, and it could be increase in requirement, like those who have got congenital cyanotic heart disease, because in those patients we have chronic hypoxemia, so there is increment in erythropoietin and stimulation of bone marrow, so there will be increased production of RBCs polycythemia, which can lead to uh, thrombosis. But don't forget that this polycythemia will lead to depletion of iron stores, and if we are not supplying them with extra amount of iron, like in tetralogy of Fallot, so this will lead to microcytosis in addition to polycythemia, and we all know that the microcytosis will aggravate the hyperviscosity of polycythemia. That's why all patients with cyanotic congenital heart disease should receive iron to prevent occurrence of microcytosis, which will aggravate the hyperviscosity of polycythemia present on those patients. Okay, what about the clinical presentation? We have to know that, of course, iron deficiency anemia can lead to features of anemia like pallor, anorexia, fatigue, and so on, and tachycardia, of course. But don't forget that iron is also an important constituent of some enzymes like uh, those of monoamine oxidase, catalase, cytochrome oxidase. All these enzymes are responsible for metabolism of the neurotransmitters, and that's why sometimes we all know that the brain its function depends mainly on neurotransmitters, and we have a balance between the stimulatory and inhibitory neurotransmitters. But what is happening is, if iron is low, so some of these enzymes will be low, so the metabolism of some of these neurotransmitters are affected. So it can lead either to stimulatory manifestation, like, for example, it can lead to irritability, or inhibitory manifestations like poor intellectual function and pica and so on, abnormal appetite. Don't forget also that iron is very important for cell cycle sometimes, and iron which is low can affect the nails, koilonychia, and the hair, loss of luster. And don't forget also that iron is very important for the phagocytosis process of cells, T cell function, B cell function. So sometimes there is immune deficiency of the patients, and maybe the spleen will be enlarged in size as an extramedullary hematopoiesis, or even it can enlarge in size due to sometimes viral infection. These are koilonychia, and these are leukonychia. And don't forget that those patients, as laboratory test, they have got to do with the back, the RBC, sorry, the CBC shows microcytic hypochromic anemia, bone marrow is hyperplastic, but the iron stores are low. And don't forget also that we have serum iron, serum ferritin, total iron binding capacity, and free erythrocyte protoporphyrin. So serum iron and ferritin are low, but TIBC and free erythrocyte protoporphyrin are increased. And don't forget that if we have a ferritin level which is low, this is good positive test, which means that a low ferritin means a low iron. But what if the ferritin level is normal or high? This is not an excluding point for iron deficiency, because sometimes serum ferritin is high not because iron is high, but because it is an inflammatory process. So we have to go further for another test, which is dividing serum iron over TIBC multiplied by 100. We call this transferrin saturation. And whenever transferrin saturation is less than 16% in children, this means that we have iron deficiency. And it's not a must for patients who have got iron deficiency to have anemia, because only 1/3 of iron deficiency patients will have anemia. So 2/3 of iron deficiency patients will not have anemia. So a normal hemoglobin cannot exclude iron deficiency. This is very important. What about the treatment? Of course, prophylaxis is very important, and we have to give the patient iron about 10 to 15 milligram daily, and we have to start iron supplementation since the age of 2 months for preterm babies. But for full-term babies, we can start iron supplementation at the age of 3 months if the baby is receiving artificial feed, or at the age of 4 months if the baby is receiving breastfeeding. And about treatment, we have to treat the cause, of course, and we have to give diet-rich in iron, especially animal sources. But if we want to give plant sources, we have to give vitamin C in addition, and avoid any chelating agent like calcium, oxalate, phytate, tannic acid, and so on. And if we want to give iron supplementation, it could be drops, it could be tablets, capsules, it could be injections. We can add lactoferrin in addition in order to increase the amount of absorption of this iron. The dose is about 2, or we can say 6 milligram per deciliter, 6 milligram per kg daily. Better to be given 2 hours after meals or 1 hour before meals. And we have to give for 3 months and even more to replenish the stores sometimes. If we want to give an oral iron, it's usually ferrous sulfate, whatever, gluconate, fumarate, succinate, and so on. But if you want to give injection, it's ferric iron. It's given intravenous, especially for pregnant ladies or for those who have got malabsorption and not responding to oral. But blood transfusion, it's not recommended. Bacterial disease is not recommended for those patients, except when the hemoglobin is less than 4 or there is heart failure or increased need for increasing oxygen carrying capacity in the ICU, for example. Okay, reaching another point, which is aplastic anemia. It's not the most common, but it's the most dangerous. And we all know that aplastic anemia means it's not aplastic, no formation, but it's only decreased formation. Better to say it's a bone marrow failure and marked decrease or absence of blood forming elements, and the bone marrow is replaced by fatty tissue. And we have to know that we have two main types of aplastic anemia. It could be congenital or acquired. And we have the congenital, about 20%, like Fanconi anemia, like pureed cell aplasia or diamond blackfan anemia. For Fanconi anemia, it's an autosomal recessive disease, precancerous disease. It's affected by a defect in the genes responsible for DNA repair. And that's why the test is called induced chromosomal breakage test, because we have to add some substance which can lead to chromosomal breakage. Okay, and don't forget also that those patients may be presented with pancytopenia, but not really at birth, but could be presented late at 2 years, 3 years, even 8 and 9 years old. Of the most characteristic features of those diseases that we have some anomalies in the patient. We have to search for in any case of anemia. And as I have said, it's an autosomal recessive, so you have to ask about consanguinity in the parents. The multiple anomalies include the absent radius, the thumb, microcephaly, renal, like ectopic kidney or horseshoe kidney and so on, or could be cardiac anomalies like PDA and dermatological manifestation like the presence of café au lait patches and other anomalies. Of course, it's a precancerous disease which can lead to acute myeloid leukemia and squamous cell carcinoma in the future. This fine girl have got microcephaly, microphthalmia, and dark colored skin. And this X-ray is for a bifid thumb. And this baby have got no radius, absent thumb, and have got a tracheostomy. Even sometimes we have what we call café au lait patches. It's very common. And of course, we have ectopic kidneys sometimes present in an ultrasound. So any baby who have got thrombocytopenia or whatever anemia, you have to search for an abdominal ultrasound to see whether we have any renal abnormalities or not. The test is called induced chromosomal breakage test, and it's done by epoxybutyrin or mitomycin C, certain acceptable range of breakage, but if this limit is exceeded, so we can call it chromosomal breakage, positive chromosomal breakage test. What about acquired aplastic anemia? It could be either idiopathic, 90%. It's not idiopathic, but it's immune dysregulation due to a problem in the T lymphocyte cytokine release. And secondary, it could be secondary to some drugs like chloramphenicol, cytotoxic agents, viral hepatitis, radiation, leukemia, chemicals, and so on. The clinical presentation include anemia, pallor, fever, increased susceptibility to infection. Of course, decreased platelet count could be bleeding tendency, but we don't have any hepatosplenomegaly or lymphadenopathy to differentiate it from leukemia. And if you go for the peripheral blood, it could be pancytopenia, decreased reticulocytic count or normal, bone marrow aspiration, and biopsy. Of course, we have to do both. There may be fatty or fibrous tissue in the biopsy mainly. And this is the needle for bone marrow aspiration. We just use a trocar cannula to go through the bone under anesthesia. And this is how can we suck blood, especially in bone marrow transplantation sessions. And this is a bone marrow biopsy showing fatty cells and necrotic cells. And lastly, we have to speak about treatment. So we have to avoid exposure for the causative agent in cases of secondary aplastic. We have to give symptomatic treatment like giving the patient blood transfusion, platelet transfusion, white blood cell transfusion, and so on, antibiotics. And for patients with Fanconi anemia, we have to go for the steroids and androgen. And for steroid-resistant cases, sometimes we give methylprednisolone. We have to give cyclosporin, anti-T lymphocyte, or we call it anti-thymocyte globulin, because this is in idiopathic patients, idiopathic aplastic anemia, not in resistant, but in idiopathic aplastic anemia patients. We don't have a cause, so we have to deal with them as immune regulation. And lastly, if all these measures fail, we have to go directly for allogeneic bone marrow transplantation from an HLA-matched donor. We have to search for hematopoietic stem cells, either from the bone marrow of a donor or from the peripheral blood of a donor after mobilization of stem cells, or number 3, we can search them in the cord blood transplantation. Of course, the most common type of anemia in Egypt is iron deficiency, the most common. Chronic hemolytic anemia in Egypt is thalassemia. Acute, it's G6PD. And don't forget that microcytic hypochromic anemia is the most common. Thalassemia is the only microcytic hypochromic anemia